what we will do is optic nerve sheath diameter. Okay, now the optic nerve sheath diameter comes as a part of POCUS. You have heard of POCUS? What is POCUS? Point of care ultrasound. So this comes as a part of point of care ultrasound. Now, what is the difference between point of care ultrasound and the usual regular ultrasound? The entire difference between POCUS and usual ultrasound is a POCUS is specifically to answer a specific question. You understand? It is to answer a specific question, number one. Number two, it's also to figure out what is how the procedure required to improve that. And the third thing is to adjust the severity as time goes. So there are three reasons why a POCUS is done. A POCUS is done, one, to answer a specific focused question. A specific focused question. For example, let's take the example of POCUS for hypotension. So POCUS for hypotension will involve you to put the ultrasound probe on the high map, the heart, the inferior vena cava, all these things are there. So we do that to figure out cardiac tamponade. So that we know that's the focus question. The focus question is why is there hypotension? That's the focus question. Unlike a general ultrasound, like you say ultrasound abdomen. So when you say ultrasound abdomen, generally what they'll do liver, they'll do kidney, they'll do things like that. But here there's a focus question here. That's why it's called as POCUS. And the last 20 odd years I've seen ultrasound POCUS going from from what it was to now. It is the only thing that we have in ultrasound per se for diagnostic purposes, for grading severity and for doing procedures. For example, you want to do you diagnose that this patient has cardiac tamponade. The next thing you do is you want to pass the needle inside. The POCUS helps you to do that. Similarly, you have a pneumothorax, you diagnose on POCUS the pneumothorax and you then use a needle to decompress. So POCUS is specifically for those purposes, of which one of the big things that we have found out in the last couple of years is optic nerve sheath diameter. Now the optic nerve sheath diameter, to understand what the ONSD is, you must take the background. The background at this moment is the fact that in order to figure out what is the pressure in the brain, everything that we have is invasive. We have intracranial pressure monitors, which are generally put as bolts into the brain, or it could be a catheter that gets into the ventricle. The only way you can find raised ICP is by putting in a intraventricular catheter or a subdural bolt, or it will be by a CT scan. In the CT scan, you can actually figure out raised ICP if there is midline shift, if the systems are obliterated, if all the there is nothing that is there, it's all grey white matter differentiation goes off, then you can say raised ICP. So this particular procedure called as optic nerve sheath diameter has actually changed the way we can monitor patients for raised ICP, because it's completely non-invasive, can be repeated, it can be easily learned. The learning curve is very small, so you can learn it very quickly, and it is very easy to do also. Doesn't upset the patient, and it is non-invasive. So where all you can use this? So you can use it everywhere. You can use it wherever you are suspecting intracranial hypertension. You can use it in traumatic brain injury patients. You can use it in patients of hypoxic ischemic encephalopathy where you are suspecting extreme cerebral edema. You can do it in stroke patients, because in stroke patients you might say that okay, stroke is in one side of the brain, how can it affect the optic nerve sheath diameter? But we know that if you follow the optic nerve sheath diameter and the diameter increases by 0.1 millimeters, every increase in 0.1 millimeter will actually increase the mortality in stroke by 4%. Okay, so every day in a stroke patient, if you keep doing your ONSD and you find the this to increase by 0.1 millimeter, it will go in favor of saying that the mortality is gone up by 4%. So as I said in POCUS, you can diagnose for the focused examination and understand what it is. The focused question that we have to ask here is there raised ICP? The second thing is what is happening over a period of time, what is happening. That is, in the starting there is raised ICP is coming down or worsening. We can know with that also. Third thing, say you have a decompression craniotomy to be done, it actually tells you that your optic nerve sheath diameter has gone from whatever it is to very high. So it needs a decompression craniotomy. It gives you the direct window into the brain. Okay. So these are the indications. You can also do it to understand shunt. Sometimes you have a shunt in place and you don't know whether the shunt is working non-functional or it is not working very well. You do an optic nerve sheath diameter. Now, why is this changing as per ICP? It is changing because for that you must know the anatomy a little bit. So the entire globe is sitting in a Tenon's capsule. The Tenon's capsule is then surrounded by the orbit and the subcutaneous tissue and all the muscles and things like that. And this is an extension of the brain. The optic nerve is the extension of the brain which is covered by the pia mater, dura mater, subarachnoid space. So at the end of the day, whatever happens in the brain will happen in the sheath that is surrounding the optic nerve. What is happening in the brain will be seen in the sheath of the optic nerve. Now, why is this such a simple thing to do? Because of the fact that the globe contains water, and water is a medium that transmits ultrasound beam. So the water can be easily seen very beautifully. That is the reason that when you're doing an ultrasound, it is very easy to actually look at the optic nerve sheath because it transmits the entire beam through the water to the back of the eyes into the optic nerve sheath. Right. So how do you do an optic nerve sheath? Which is a position that we normally use in this. You normally can use either in supine or you can do it in a 30-degree propped up. Either in a supine or a 30-degree propped up is what you're going to do it as. So here we have a patient who's in a 30-degree propped up. Okay, they might say do it in supine, do it in propped up. Doesn't make a difference. So 0 or 30. This is what it is. How do you do it? You actually put tegaderm to cover the eye completely. This is very essential. And why is this essential? Because of the fact that if you want to put it directly on the eye, there is a possibility that the jelly will get into the globe and cause problems. Which probe do you use? You use a vascular probe. A vascular probe is what you would use. A linear probe, it's also called a linear array probe. Why do we use a linear array probe? No, because of the fact that the superficial structures are seen much better than the deeper structures. The more different probe you use, for example, you use this probe, you see the deeper structures better. That's why it's used to sound the heart. Okay, this is a curvy linear probe. This will actually make you see deeper inside. That's why you can see everything right from the lungs to the kidney to the pancreas with this probe. You understand? You can do all these things. Okay. So now when you're doing this now, essentially what you're supposed to do, you use a linear probe over here. Linear probe. So you change to the linear probe on this. Okay, linear probe, which is the vascular ultrasound. And then the key to this is to ensure that you don't put pressure on the globe. So you use a jelly that is a good generous amount of jelly. So you use a good amount of jelly. It should be a good generous amount. Okay. So the answer is to put a lot of jelly. You can't just put very small amount of jelly because if you put pressure onto the brain, put one more jelly. Go jelly. If you put pressure on the eyes, the pressures will change. So when you're doing an ultrasound for optic nerve sheath diameter, you have to use your palm here. This is the only place where you're using your palm. You can't be using the ultrasound directly. You can't place it. You can't hold it like this. You can't hold it like this. Okay. What you're doing in such cases is you are going to. So you are going to use your hand as the base. So your hand can be used as a base like this, or your finger as a base, or you can go to the head end and keep your hand, because the probe has to be in the air. The probe cannot be pressed. The probe can only be sounded. So for that, I need to ensure that my hand is placed either on the face like this, or my finger on the face like this, or I go to the head end and keep my hand like this and keep my probe like this, so that I don't move the probe. I cannot do it like this. This is wrong. Okay, so it has to be kept in such a way that you keep it in such a way that you don't keep any pressure on the probe, and this is what you will see. So what you're seeing over here, and here you see open up the optic nerve sheath. Once you do this, freeze the image. Okay, you freeze the image. So what you're seeing over here is the globe, the aqueous humor, and you're seeing this anechoic structure, which is the optic nerve. What you're seeing here is the anechoic structure, which is the optic nerve. Okay. As I told you, this is something that is coming from the brain and going into the globe. That's why this is the anechoic structure that we're looking at. This is called as optic nerve. Okay. Now in this, the structure that you can see around it, the straight structure around it, you see is the sheath, is the optic nerve sheath. Optic nerve. Once it reaches 7.5, it plateaus. There is no more space for that sheath to expand. Once it reaches 7.5, it is kind of plateaued. 7.5 is from where it will not go further higher. It will not go to 8 and 9. It is not going to go to that level. After that, the ICP cannot be correlated per se, but you can say it's high. You can say it's high. Optic nerve sheath diameter will say it has gone high otherwise. Clear? Any questions on the optic? So where we cannot do this? You will not be able to do this if you have an eye injury. If you have an eye injury, you can't use it. If the globe is kind of penetrated by penetrating injury, you can't do it. If the patient has got chronic conjunctivitis, keep quiet. If they've got chronic conjunctivitis or there is redness or chemosis, we can't use this. You can't do this because you are subjecting this patient to other problems at these stages, right?
After admission, how many hours or hourly we do?
Nothing like that. So, say for example, you have a patient that is you're there in the ICU and your patient came in with a traumatic brain injury. You immediately first look at that optic nerve sheath diameter the moment you have the time to do it, because it takes you not more than a minute or two to finish it off. And once you do that, you will get the answer whether there is raised ICP. Now, in the meantime, you figure out that this patient's overall condition has suddenly worsened. Now you want to figure out what has worsened it. Is it metabolic abnormalities or it is raised ICP that is causing it? All you do is go back and again check it. Go back and check it. You find it increased, you can say, okay, it is the ICP that is causing it. Similarly, your treatment. For example, you have a patient of raised ICP, and now you found out that whether my treatment is working. As I told you, focus is for for a focused answer, focused question it answers. So now you have a situation where your patient had raised ICP, you found it was 0.6, and now you have put measures where you are kind of reducing your EtCO2. Now you are reducing your EtCO2, your carbon dioxide is washing out. You expect the ICP to come down. Okay, then you may come back and check it again. See what has happened to it, whether it has come down or not. If it has come down, yes, it is working. Your measures are working. You give mannitol, want to see what happens to it. Your measures are working. So it's a very simple technique to figure out whether this patient has got raised intracranial pressure. Very simple technique. But the real thing is, try to do it the right way. So there are other studies also that says you can measure it 8 millimeters away from the globe also. There are other studies. So there are two ways of doing this. One is to measure at 3, other is measure at 8. Normally you want to measure at the bulbous part. This is the bulbous part of the optic nerve sheath. So this is, otherwise it becomes cylindrical. That part is the bulbous part. So normally, that is why most of the studies look at the bulbous part of the optic nerve sheath. They don't look at the 8 millimeter mark. The 8 millimeter mark is somewhere down here. It will be a little bit narrow. Okay, so that's why we want to look at the bulbous part of the optic nerve sheath. The real thing is, do 3 millimeter behind, mark it, and then take it. Now, sometimes it does also happen that your optic nerve sheath diameter will be eccentric. That's okay, no problem. But measure it. Sometimes it may be eccentric. If it's eccentric, that is, it is moving this way, it's okay, no problem. Measure it, no problem. You can still measure it. Do 3 measurements. Do 3 measurements for any of this. Is there a specific method to place the probe? So there is no specific method. It all depends on how you do it. So if you want to place it straight this way and you can't see anything, let me take this example here. I can't see the optic nerve sheath properly here. Okay, if say for example, keep it like this, I can't see it. I just tilt my probe, figure out where I'm reaching. See this? It all depends on how you're going to do this. So if I do it like this, yeah, I got it. Saw that? So there is no specific angle in which you put it. You press it, you place it, and then you turn it. Answer is, don't press it hard. Don't press it hard. Clear? So this is all about optic nerve sheath. Anything to ask on optic nerve sheath? Anything further? So it is a simple baseline investigation, and I think everybody in the ICU should know it. Without knowing it, because now at this moment in our ICU, there are 5 patients who requires an ONSD to be done. At least 4 patients are there. All those 4 can be evaluated to figure out. What we found on all those 4 patients are there is no raised ICP at all. We found on this, that, this, all the patients, there was no raised ICP, very clearly indicating that we don't have to do anything further. Mannitol is not even required. You understand all of those patients? Okay?